this is a continuation from my CVS general principle of this thing. So it all goes back to Ohm's law. So Ohm's law is an electrical law which says V equal to IR, V is the volt, I is the current in ampere, and R is the resistance in ohms. So this can be extrapolated in all systems in our body. When you talk about renal physio, cardiovascular physio, respiratory physio, all these things can be. So it's basically Ohm's law saying pressure is equal to flow times resistance. Any change in pressure is equal to flow times with the resistance to the flow. So this is the pressure. So how we can manipulate this is, in cardiovascular system, it goes to MAP. Mean arterial pressure is equivalent to cardiac output is the flow times the systemic vascular resistance. The resistance to this flow, to the cardiac output, is the change in pressure that we observe. If you put in a respiratory system, it goes in the compliant. Okay, compliant, when you think a change in pressure is equal to change in flow of the air over the resistance. Either it can be airway resistance or chest wall resistance. So you can extrapolate and play with it, this formula Ohm's law, in all the system. So idea is, inside cardiovascular system, its mean arterial pressure equals to cardiac output times stroke vascular resistance. Systemic vascular resistance. So in cardiac output, when we rearrange it, it goes back to mean arterial pressure divided by systemic vascular resistance. So cardiac output, as we know, as a simple equation, is equivalent to heart rate, the times the heartbeat per minute, times the stroke volume, means that volume of the blood ejected from the left ventricle per ejection, okay, per systole. And mean arterial pressure, we know, is cardiac output times the systemic vascular resistance. So when we rearrange it, you get, so cardiac output equal to heart rate times stroke volume, and your stroke volume is dependent on afterload, which is your vascular resistance, preload, which is your volume, okay, your venous return, and the centrifugal, and contractility, the force of LV contraction. So all these contribute to your cardiac output. So cardiac output is equal heart rate times stroke volume, and your MAP is equivalent to cardiac output and stroke volume. So if you put these into this, your MAP is equivalent to heart rate times stroke volume times systemic vascular resistance. Okay, your blood pressure is depends on the heart rate, depends on stroke volume, and it depends on the systemic vascular resistance. Okay, that is the full equation of a blood pressure. So again, we go to BP equivalent to cardiac output and systemic vascular resistance. Cardiac output is stroke volume times heart rate, so which is depend on this. So if you put everything, MAP is equivalent to heart rate times stroke volume times systemic vascular resistance. This is the full thing. So again, it goes back to the Ohm's law. You remember this, you can play around and you can use it in day-to-day activity as well. As a simple example, again, I go back here. When you talk about it, MAP equivalent to heart rate stroke volume times air. So you give a spinal to a patient. After spinal BP drop, okay, it's sympathetic blockade. You have a vasodilation, and also sometimes you have bradycardia. If the patient is young and his cardiovascular system or compensatory system is okay, the moment patient develops sympathetic vasodilatation, means peripheral venous pooling, reduced venous return. So your stroke volume is reduced. As a compensatory mechanism, two things are reduced after your spinal. One, you have systemic vasodilatation, so your systemic vascular resistance is dropped. So BP drop. You have venous pooling, so less venous return, stroke volume reduced, BP drop. As a compensation, you have tachycardia. Your heart rate will go up to maintain the blood pressure. If that cannot maintain the blood pressure, the BP will drop. So that is why what we do, we give fluid. We give fluid to push up the stroke volume. We push up this left ventricular and diastolic volume. Okay. So next, we give vasopressors to vasoconstrict to increase the systemic vascular resistance. Let's say if the patients have bradycardia as well, after that, that's why you give ephedrine. Here you give phenyl. So, but if the heart rate is as also low, you have to give ephedrine to push up this, and also the force of contractility of the heart, because contractility is here. So your ephedrine will push this and this, and your phenyl will push the afterload. It will cause vasoconstriction and increase systemic vascular resistance, and your preload by giving fluid. So this is the idea of using this equation in your day-to-day life. Okay, even in patient in septic shock, that's the same thing happen. Patient in septic shock, they have systemic vasodilatation. So that's what happened. That's why they have a BP drop. Patient with cardiogenic shock, they have contractility issue. Okay, that's why the BP drop. So all these are goes for patient with hypovolemia, they have problem with preload, venous return. That's why they have a BP drop. So all types of shock, if you talk about it, you have types of shock, hypovolemic shock. In hypovolemic shock, your problem is your preload. In patient with cardiogenic shock, contractility. In patient with distributive shock, either sepsis or spinal, the afterload is affected. Patient with obstructive shock. So patient with obstructive shock, like in pulmonary embolism, they have no problem with heart rate. They have no problem with systemic vascular resistance. They have no problem with volume. The problem is ejection is impeded. The heart is full, but it cannot eject the blood out. There is obstruction. So the stroke volume will be reduced. So that's how it affects the MAP. So you want to go through your types of shock and everything. You have to think about this as well. Cardiac output monitoring, it's also known as advanced hemodynamic monitoring. Okay, in this topic, there is a lot of equations that you have to know. I want you all to go back and read immediately on cardiac output topics, or in within few days on cardiac output topics in Carey Brandeis. No need to read any pages, 2-3 pages in Carey Brandeis, and there's another 2-3 pages on oxygen transport under respi system in Carey Brandeis. Read this so you will know a better idea. I will go through the summary of those things included here also, because your cardiac output monitoring based on few principles and equation which relates to all these things. Okay, when we talk about cardiac output monitoring, we're talking about advanced hemodynamic monitoring, like what you all see lah, your Vigilio, flow track, Pico, all these things are cardiac output monitoring. But there are even many other ways that you can measure cardiac output monitoring. Okay, so again goes back to here, your cardiac output monitoring means you are measuring the output from your left heart, how much is coming up. This is the what you want to measure. Okay, this is all the same thing again. Before we go into the topic, there are few things that you must know. The normal hemodynamic values, which is your stroke, we leave it this first. You go to stroke volume 50 to 100 mil. Stroke volume means how much of the volume being ejected from your left ventricle, which is end diastolic volume at the end of your diastole when the heart is fully filled, minus end systolic after the ejection. So 120 minus 50 is around 70, like usually the normal one. Okay, stroke index is always volume divided by index lah, is by your body surface area. Cardiac output is 4 to 8 liter per minute. It's around 500 ml per kilogram. So which is you calculate around 70. If you calculate around 70 times, it's stroke volume times heart rate, your cardiac output, right? Heart rate times stroke volume, your heart rate around 70, your stroke volume around 70. 70 times 70, you comes out around 4,900, which is around 500, 5,000 milliliter, which is 5 liter per minute lah. Okay, cardiac output equal to stroke volume times heart rate. Your heart rate, let's say you take around 70, your stroke volume is 70. Okay, 70 times 70, you get 4,900, which is almost 5,000 ml, which is 5 liter. Okay, that is how you calculate your cardiac output. Next, you have your MAP. This all you all know. Next, you have to know your SVR. Okay, systemic vascular resistance. This is all are calculated. We can't measure all these. These are calculated in algorithm. And stroke volume variation is how much is the variation for you to know a fluid responsiveness, and ejection fraction, normal 55 to 70%. All these, the machine will calculate based on the algorithm. So, and few other things you must know. Oxygen parameter, oxygen delivery, what we call as oxygen flux, is arterial content of oxygen times your cardiac output. This 10 is because you're using a millimeter mercury. Usual range is this. All these I'm just leaving it for your references. Okay. So the methods of cardiac output measurement. let's say in the SAQ, the first opening question might be list various types of methods of measurement. You classify it as this way. The most invasive way is using a PA catheter, pulmonary artery catheter. Okay, so pulmonary artery catheter, also known as Swan Ganz catheter. So that is the PA catheter. Next, less invasive. They are still invasive, but not as invasive as PA catheter. Your PA catheter goes from your IJC all the way to pulmonary artery. It's very invasive. So less invasive, you use transpulmonary dilution, whether you use PICO. PICO is pulse-induced cardiac contour output analysis, or LITCO is lithium dilution cardiac output analysis. They are invasive as in you need a central line, you need an art line, usually femoral art line. You need a bigger cannula arterial art line. So they are invasive still, but not as invasive as a PA catheter. Next, we have is pulse analysis or pulse pressure variation, like your flow track, PHYSIO, MOSCAR. They mostly need a CVS and a peripheral art line, not a central art line. Okay. Next, using ultrasound or Doppler technique by doing a transesophageal echo. When I do a transesophageal echo in an OT or anything, we'll measure the cardiac output, we'll measure the left ventricular outflow tract index, all that will measure and give us a cardiac output as well. Or esophageal Doppler technique. Okay, also doing a esophageal but using a Doppler technique, not an echo, but using a esophageal probe. They'll just put in a probe without a visualization. The Doppler will calculate and give us a value. And after that, we have a non-invasive technique such as transthoracic echo. The normal echo we do bedside also can calculate our cardiac output, same by using your measurement of your chambers and then putting your heart rate and everything. They also can calculate. Okay, and another method called thoracic bioimpedance. Next, we have ultrasound based ASCOM. ASCOM is you do an ultrasound of the heart, not really echo, ultrasound of the heart, where you put your probe over the mitral valve and you put an aortic valve and you see the flow across this valve and the output, and that will give you a outcome, the cardiac output. And finally, doing a cardiac MRI where we inject some dye and we measure from there. Of course, the most invasive one is the gold standard and give you the most accurate reading, which transpulmonary dilution almost can be almost comparable, but the others are less accurate, but they have less complication and less invasive, and they give somehow a comparable reading compared to the PA catheter. PA catheter is very invasive, very cumbersome. You need expertise for that, and it's high risk of infection and complication and pulmonary infarction. A lot of things can happen. Okay, so that's why we are moving towards less invasive or if can, non-invasive method in a non-required patient. These methods are used but still being heavily criticized. These are being very famous now. PA catheter is losing its famous popularity nowadays. Okay, so I'm sure all of you have seen this. This is PHYSIO flow track. So these are the system. This is another new one, MOSCAR. Then this ASCOM. So I'm not going to go into this. We don't have to know the brand of it. Okay, you in exam, you actually don't have to mention the flow track PHYSIO also. Okay, you can just transpulmonary dilution, pulse analysis method, ultrasound Doppler method. You can mention like this is enough. If you don't remember the name, is always okay. Okay, we just have to list down the example. List down the types, not the example. So next, this is not for exam purpose. This is for day-to-day practice and your understanding. I'm just leave it here. This is from an article. This I use for my final year exam. Okay, in final year exam, we need to know this in detail. So I'm just going to leave it here. You all can read. So you see, invasive method is pulmonary artery catheter. Less invasive, you have transpulmonary dilution, pulse contour, and pulse pressure variation. Transesophageal echocardiography, esophageal Doppler. Non-invasive method, you have TTE, you have bioimpedance, and ultrasound cardiac output monitoring. Okay, they have these advantages and major disadvantages. You can look at it, all these things. And the examples I say, you don't have to know the examples actually. You just know these methods is enough. Okay, and the advantages and disadvantages are for your day-to-day practice. You know, understand why we sometimes use that and the other one. And again, all this also the same thing. I find this will be useful for you in case, because nowadays many of the patients will use it, especially if you are in KTC side, we still use it. Okay. Okay, the principles and equations that involve in a cardiac output monitoring are two main principles. One is Fick principle, where you must know your equations. And then next is your Stewart Hamilton equation, which is a modified algorithm derived from the Fick principle. Okay, Fick principle is like a direct measurement method, which is quite cumbersome and need a lot of measurements. But Stewart Hamilton is used in PICO in a transpulmonary dilution. So when we talk about PA catheter, we call it thermodilution. But when we talk about using PICO, we call it transpulmonary dilution. I'll come to it later. Okay. So the idea is like this. When you talk about Fick principle, what are we measuring is volume of oxygen. Okay. The oxygen that goes in, the oxygen that comes out, minus this is the difference that oxygen being consumed. How much went in and how much went out. The differences is how much has been consumed by the body. So how do we know? We will measure the concentration of the arterial oxygen supplied and concentration of the venous oxygen which comes back. The differences in these will be the arteriovenous oxygen concentration difference and oxygen consumption. So I will come to explain in a while how we actually got this equation. Okay, this is just an overview. Stewart Hamilton equation used in PICO method is almost the same, but instead of oxygen, they use a dye. They use an injectate. Okay, the injected that goes in minus the injected comes out. That is the difference times the volume. It's almost the same thing. Okay, it's just the method that being used. The idea is the same, but the method is slightly different. Instead of using oxygen, they're using a dye here. Okay, Fick principle. Fick principle states a blood flow to an organ is equivalent to rate of uptake or excretion of substance divided by arteriovenous concentration difference. Okay, the flow is equal to how much is the things being consumed, uptake or excreted, divided by the concentration that went in minus the concentration that comes out. Uptake or excretion of a substance by an organ must be equal to difference between amount of substance entering minus amount of substance leaving the organ. So amount entering, how do we know? Arterial is the entering flow. So times the arterial concentration. Let's say I give a substance X, inject it in your blood. So the arterial flow is the one that brings to it, goes through the arterial concentration minus the venous flow, venous concentration, the ghost that comes up. The rate of uptake or excretion, okay, that is consumed, how much that. In case of oxygen, how much oxygen consumed, okay. In arterial concentration, oxygen times the flow, venous concentration times the flow. That is the differences. If we talk about oxygen, oxygen that entering will be your arterial concentration of oxygen, arterial flow, your venous flow times venous concentration of oxygen. Flow is the same, the blood flow is the same that goes in and out. The difference is the concentration. So you rearrange, this is your concentration. So the oxygen consumed is the consumed, the rate of consumption is equivalent to flow times the differences in arteriovenous concentration. You rearrange because we want to get the flow. We want to measure the cardiac output, right? The flow. This is what we interested. The Q is equivalent to cardiac output. Rearrange it. Your Q is equivalent to consumption of a rate of consumption divided by arteriovenous difference. So this one. Rate of consumption divided by arteriovenous difference. You see the oxygen consumption. This is your CaO2, this is your CvO2. The difference between these two is this. Your cardiac output is equivalent to oxygen that is consumed divided by the arteriovenous difference. AV oxygen difference is CaO2 minus CvO2. So in this Fick principle, you must know oxygen consumption, you must know the oxygen delivery equation and how we calculate oxygen content, arterial and venous, and minus this will be your arteriovenous oxygen difference. So let's look at it. Okay, this is your oxygen being consumed. This is your difference in your arteriovenous oxygen consumption. Okay, your oxygen consumption VO2, the standard oxygen consumption of an adult person is 3.5 ml per minute per kilogram. That is why we call it one metabolic. When you do a pre-med assessment, when you say med, right? Med 4, med 5, med 6 is it? how much they use the oxygen. Your metabolic equivalence max is calculated based on how much is the oxygen being consumed. Okay, if the patient is, when we say higher max, it means it's good. Patient is using higher oxygen. He can able to increase his oxygen consumption to do the strenuous activity. When we say patient is mat 7, mat 10, it means his heart can push up his oxygen consumption for him to do that kind of strenuous activity. If you say a patient is mat less than 4, it means he is unable to push. 4 times 3.5 is 12 mil per minute per kilogram. He can maximum only push up his oxygen consumption that much only. His heart cannot sustain more than that. That is why it is poor max. It means it's not good effort tolerance. So that's how we calculate your max. Okay. So in a 70 kg adult, 70 times 3 is 245 mil per minute. So in a resting adult male, like let's say a male, average adult is sitting and not doing anything, per minute is using 245 mil of oxygen, roughly around 250 mil. So if we look at it, let's say the arterial oxygen content is 1050 mil per minute. You are giving it. This is just an example. 1050 mil per minute oxygen is going in. It goes into systemic circulation where it's being used up. Then comes back, you measure, only got 800 mil, mean 250 mil has been used up. Okay, 250 mil been used up. Whereas your CO2 arteriovenous oxygen content, this is the content difference, is 50 mil. So 250 divided by 50, 5 liter per minute. This is just the overview. We'll go to the equation now. So how do we calculate this CaO2 minus CvO2? How do we want to calculate the differences in content of oxygen blood in arterial and venous? This one we already know, 3.5 mil minute per kilogram. So if we get the weight of the patient, we can find out. So we go back to this equation. For you to find out the cardiac output, you have to know this VO2, which is the oxygen consumption, and arteriovenous oxygen difference. These I have told you we can calculate from here. If a patient is given the weight, you just times with 3.5 mil, you will get. So you will get this value. You have given this value. So now numerator you got. Now you're looking at denominator where you want to know the arteriovenous oxygen difference. How do we calculate? So oxygen content in blood, we have to calculate two things. Your oxygen in your blood is present in a hemoglobin bound form and in a dissolved form. Dissolved form is very little, minor. Actually, you can omit also sometime, but this is for completion's sake, I will mention. This is why you have to go and read your Carey Brandeis, page 121. You have to read about the oxygen transport. So hemoglobin bound oxygen and dissolved oxygen. How do we count hemoglobin bound oxygen? This is the oxygen carrying capacity of your hemoglobin. So how do we calculate? We'll calculate hemoglobin concentration time SaO2, which you can also put via your. So how do we get this information? This information, you see, look at your, let's say you do an arterial blood gas, ABG. When you take ABG, you get all this information. So your hemoglobin bound oxygen being calculated by this formula, 1.34 times hemoglobin times SaO2. I will come to what this constant, and you have to calculate your dissolved oxygen via that. Whether it's arterial or venous is based on what type of blood you are taking. Let's say you took an ABG and using the value from that, you are using an arterial oxygen content. You take an ABG, you put in the hemoglobin from the ABG, and you put the SaO2 which you get from your ABG, then you put the PaO2. Okay, what is 1.34? This is called Affness constant. What is Affness constant? It means oxygen combining capacity in mil oxygen per gram kilogram. It means 1 gram of hemoglobin has the capacity to combine 1.34 mil of oxygen. Okay, 1.34 mil of oxygen. 1 gram of hemoglobin can combine 1.34 mil of oxygen. This is constant called Affness constant, HUFNER. In some books, you may see this constant be given 1.39. 1.39 is the ideal value that mentioned in book, but we have to take into constant, not all our hemoglobin are perfect adult hemoglobin. It is not a HbA. A lot of our hemoglobin are methemoglobin. We have a lot of carboxyhemoglobin, which all doesn't have the perfect oxygen combining property. That is why it is given a bit of reduction, putting at 1.34. 1.34 is the practical roughness constant, not the ideal. Ideal one is 1.39. So if you see in books 1.39, don't get worried. That is the ideal one. This is the practical one. Why it is lower? Because we have to give some correction for methemoglobin and everything. Okay, so you take ABG, you put in this value, you get COO2, arterial content of oxygen. Okay, oxygen in arterial blood, you get it already. Okay, what is 0.031 is the solubility coefficient of oxygen in millimeter mercury. How much of oxygen can be soluble, can be dissolved in blood per millimeter mercury. That's why you put your PaO2. Let's say you take an ABG. In the ABG, the SB is 10.1. You put it over here. SaO2, it shows around 95, 96. You put it over here. PaO2 is 100. Then you put all this value, you calculate, you get your CaO2. All these units must be correct. Your PaO2 must be millimeter mercury, and your HB must be in your, you say hemoglobin must be in, hemoglobin in 100 message. It will be mentioned in gram per 100 mil. And then your SaO2 must be in decimal point. Let's say your SpO2 shows 97%, so you have to put 0.97 in decimal. Then only you can get. Same goes to CbO2. So we get this CaO2. Now we get a CbO2. Simple. You take a VBG and you just put in your VBG. To get VBG, the HB is going to be the same. The SvO2, it should be around 70, 75 only, not going to show 90% or what. And PaO2 will be also lower. And you know, ABG and VBG, it's all differs. So then you get your CvO2. Other values derived all are same as the hemoglobin going to be the same. Your HB going to be the same. These values going to differ. The SaO2 and PaO2 going to differ. So you're going to put that. Then you minus this. Then you're going to do this CaO2 minus CvO2. So you will come to equation VO2 over CaO2 minus CvO2. Then you will get your cardiac output. That's how we calculate. Oh, forgot. I had an example here, but I don't have it. Put it there. So you can just calculate it lah. Okay. An example, you have a 70 kilo patient, as I mentioned. So you put a 245 mil over here. Sorry, 245 mil over here, and then the difference of CaO2 minus CvO2 here, then you will get your cardiac output. So remember this equation, okay? And how do we get CaO2 and CvO2? You must know this equation. This is calculation of oxygen content in blood. This is calculation of your cardiac output. So another one is oxygen delivery. This is not actually involved in Fick principle, but it's related, which is the oxygen delivery. We call it oxygen flux. It's the same thing. It means you have certain amount of oxygen in your arterial blood. You just have to times with your cardiac output to tell how much oxygen being delivered. So you have your cardiac output. You measure your cardiac output first. You get this value. Then you already have your CaO2. You already measured this. Then you just put it over here. Cardiac output, this is your CaO2. The same thing. This thing, you put it over here. Then you times your cardiac output because you already counted your cardiac output here. Then you can calculate your delivery of oxygen. Rate of oxygen delivery, milliliter per minute. Okay. So everything else you can get from the previous equation. That's how you calculate your oxygen flux. So when you have your Vigilio flow track, if you put in all this information, the machine can calculate for you. There is a screen where you can put in patient SaO2, we can put in patient's ABG, HbA, PaO2 and everything. The machine we can calculate for you the DO2 also. Next, what we have is Stewart Hamilton equation, which is a derivation from the Fick principle, which is used in PA catheter or PICO as well, okay? But use a thermodilution technique. Rather than calculating oxygen, for you to do this, you have to do all these things, okay? But when you have a device, you can use a thermodilution technique where you inject something, mostly cold saline, okay? And you measure the temperature change. That's why it's called thermodilution technique, okay? When you inject a cold saline, your blood is warm. usually our blood is warm inside, okay, our core temperature. So when you inject a cold saline, there will be change in temperature. This is the change in temperature. Just hold on. So this is the temperature change. So what happens is when we inject a cold saline into our blood, it will go a temperature change will be picked up by a thermistor in the PA catheter. There is a sensor that can actually detect the change in the pressure. Okay, either in a PA catheter or PICO, we use different system. I will explain what's the difference between PA catheter and PICO method, because this is very invasive, this is less invasive. How does it matter? So in this, you just have to remember this. You don't have to remember the whole thing. You can just remember this. Cardiac output equal to amount of injected indicator divided by area under dilution curve. This area under dilution curve, amount of injected indicator. The indicator is your cold saline lah here. So how do we do that is you have a correction factor times temperature of the blood minus temperature of the injected times the volume injected. If let's say you inject 20 mils, the temperature of the blood will be picked up by the machine, and the temperature injected also will be picked up by the machine, and then the temperature change will cause the area under dilution curve, and then you get the cardiac output. Don't get confused or don't get too overwhelmed by this. You don't have to actually explain this. You just have to remember the concept of it. It's a thermodilution technique. We inject a cold saline into the warm blood, and the temperature change will give us the cardiac output based on the flow. It goes on. There is a Stewart Hamilton equation. It's derived from that. Okay. So what happens is in a PA catheter versus in a PICO, the difference is in a PA catheter, we'll talk about PA catheter in a while. Your catheter will go and placed in your pulmonary artery where there is a thermistor there. So when you inject a cold saline here, it will go through the warm blood, and by the time here there will be the thermistor will be placed here. You can see this is the catheter. Inside this thermistor, before we inject the cold saline, it is picking up a warm blood temperature. It knows the warm blood temperature. And then you inject a cold temperature, a cold fluid. The cold fluid will travel all the way and reaches this thermistor. The moment it reaches the thermistor will pick up that cold temperature. That what will goes into your temperature blood minus the temperature injected. So the time taken for this cold saline temperature to reach this thermistor here, it's the way they calculate the cardiac output. The cold injectant is introduced into the right atrium through the proximal injection port of a pulmonary artery catheter. The injection solution mixes completely with the blood in the right ventricle. The cool blood then flows into the pulmonary artery, and a thermistor catheters register the change in temperature of the blood. So this is this overview of how we do a thermodilution in PA catheter. Okay, understand? Same thing goes in PICO. How do we PICO, which is less invasive, is we don't have a PA catheter, but what we do is instead of a PA catheter, we instill the bolus injection in a central line in a CVP, in a IJC, but it is being measured in the femoral art line. So in PICO, you need femoral arterial line and a CVL in the IJC, okay, in the upper part of the body, either subclavian or CVL, and then the measurement of the cold saline happens in femoral art line. So it's a longer pathway, but it's less invasive. You don't have to put a PA catheter. So rather than thermistor or that temperature change picked up by the thermistor in the pulmonary artery, it is being picked up in the femoral artery all the way down there. And they have their algorithm using the Stewart Hamilton and calculate for you what all you need, all these things. Okay, so that is the differences between the thermodilution. The method is the same, the technique is the same, just the method, one uses the PA catheter and it measures the temperature change in the pulmonary artery. In PICO, it measures the pulmonary temperature change in the femoral artery. That's all. So you see, look at it here, this is PICO. The central venous catheter, we will inject. Okay, this is where we inject. This is connected to the cable of thermistors, and then the pickup arterial thermodilution catheter is down there. This is where your femoral artery it decides. So that where the changes happen. You can see the thermistor, the cable is connected one to the injected probe, and then another one at the femoral artery probe. So the thermistor in PICO is situated outside the body, not inside the body. Okay, but it detects the sensation, the temperature change at the femoral artery and also the CBL here. Okay, so next, another thing that you all have to know is Swan Ganz catheter, just the anatomy of it and how to use it, what are the few methods to use it and complication. No SAQ, but MCQ is quite famous. Okay, we go very brief. This is your Swan Ganz catheter. It is a flow directed. I'm just going to give you all the important tips and the word that you have to remember for MCQ. Okay, it is a flow directed catheter. It means you don't push it without, and you don't push it suka hati. You insert up to the central line. After that, you have to make sure it follows the flow from your SC into your RA and to RV, then your pulmonary artery. It follows the blood flow. You cannot, it's why it's called flotation. You float pulmonary catheter. You don't insert. You float the pulmonary catheter. That's why with the name we float, because we let it float according to the flow of the blood from one chamber to another chamber. It measures pulmonary capillary wedge pressure, which is equal to pulmonary artery occlusion pressure, which resembles the mean left atrial pressure, which is equivalent to left ventricle end diastolic pressure, which is a preload, which is on 5 millimeter mercury. So all these are same. They are inter-resemble. What we're measuring is pulmonary capillary wedge pressure, because we are wedging the catheter in the pulmonary artery, in pulmonary capillaries. Okay. So we are occluding. When wedging means we are occluding the, it's called pulmonary artery occlusion pressure, which can give a resemblance, because from your right ventricle, your pulmonary artery goes, your anatomy, from your right atrium, right ventricle, pulmonary artery goes to your heart, then to the lungs. From the lungs, it comes back via pulmonary vein to your left atrium. Okay, it's a connection. So that's why it gives a mean left atrial pressure and left ventricular and diastolic pressure. It is 110 centimeter long. It is always 110 centimeter long. It's universal. It's 5 to 8 gauge. The gauge can differ between adults and pediatric adults and different sizes of adult. It can be 5 gauge to 8 gauge, or usually 7.5 franc. It has multiple lumen at 10 cm interval. Okay, they have mentioned the marking is every 10 cm. Okay, there's multiple lumen. We'll go into it. And there is a thermistor which measures the temperature change 4 cm from distal tip. You see, this is a distal tip. Within 4 cm, here you have a thermal filament. Okay, this is your thermistor. And thermoregulatory cardiac output measurement, your thermodilution by using Fick principle. I just put the important words. I don't want to put a lot of information. Then this can come out as in PHYSIO. Will only be accurate if in wedge zone 3 of the lung. Okay, I'm not going to talk about wedge zones now. There's a totally respi topic. If you have read that respi topic, you have know what is zone 1, zone 2, zone 3. If it only accurate when it's in zone 3 of the lung, where pulmonary artery pressure more than pulmonary vein, more than pulmonary vein. If the pulmonary venous pressure is higher than pulmonary artery, then it won't be accurate. If airway pressure is high, it becomes zone 1 or 2, because your pressure airway is very high. Okay, then it becomes zone 1 or 2, then it's not accurate. Just remember these words, okay, if it's too confusing for you. So it has 4 to 5 lumen. One is a lumen for you to connect to your thermistor port. It detects your temperature change. Okay, this port. Next, proximal injected. This is where we will inject. This is your pulmonary artery distal catheter. So this is your distal. This is your catheter, pulmonary artery port, the last one. And then you have a port to inflate the balloon at the pulmonary artery to occlude it. And RA infusion port is an extra lumen for you to infuse fluid directly into right atrium. Your CBL, your CVL, IJC usually at the tip of SBC. It doesn't go into RA. But this one, there is a lumen that goes in between. So it will opens up the same catheter, but it's multiple lumen opening. One opens at the RA infusion port usually opens at the right atrium for you to infuse fluid. The tip of a pulmonary catheter will pass through the right atrium into the right ventricle via tricuspid valve. You see, this is your pulmonary artery catheter. Okay, it goes right atrium, tricuspid valve, and goes into your right ventricle. Okay, then from the right ventricle, it goes into your pulmonary artery. This is your pulmonary valve. It goes into your pulmonary artery. Okay, so when you put in here, you only push all the way here. After that, you push via your flotation technique. Okay, it goes float according. We never inflate the balloon, you know. The balloon will be only inflated at the pulmonary artery. We'll just let it go, flow, flow, flow. Then the moment the balloon will be inflated and it will cross the pulmonary valve over here, and it will cross the pulmonary valve according to the flow and enter the pulmonary artery and eventually to wedge. Because when you inflate your balloon here, the balloon can be only inflated to 1.5 cc. You can see this syringe only allow you, this syringe is to inflate the balloon. It only allow you to inflate 1.5 cc, not more than that. 1.5 cc only. It is already locked at 1.5 cc. Okay. So the moment we already pass into the right ventricle, we will inflate the balloon, and the balloon will go through here. It will still able to go through the pulmonary valve because it's only 1.5 cc inflation. But the moment it goes into pulmonary artery and the capillary circulation, the vessels are very small where this balloon can occlude them. There will be a resistance where we'll stop. So the balloon will be inflated and will then cross the pulmonary valve to enter the pulmonary artery, eventually to wedge or occlude the artery to give an indirect measure of the left arterial pressure. So how do we know we are in right atrium or right ventricle or we are in pulmonary artery? We are looking at the pressure and waveform changes. That is why we are always have to look at the waveform. Instead of a CVP waveform, it will change pressure and waveform, so we know where are we. Okay. Sometimes we can use our TOE to guide as well. Okay. So this is what the pressure change and the waveform change. The pressure change in right atrium, usually you know 0 to 12 millimeter mercury. Your right ventricle 2 to 25, pulmonary artery is 12 to 25, and once you occlude, this 12 to 25 become 8 to 12. So you look at it. This is your CVP. Okay, this is your CVP in right atrium, normal. When you put in a central line, your central line will at your tip of SVC, right? So SVC, you will get this. This is your CVP waveform. Then it goes into right ventricle. The moment it goes into right ventricle, the pressure will increase. The pressure will go up to 25, almost up to 25. Okay, so you can see the pressure goes up to 25, but your diastolic is still very low. So you look at it, 25 and 2. Your right atrium, 12. Maximum is 12, around there. Maximum can go up to 12. Then, so when you go to right ventricle, it's 25 and 2. 25 and 2, around there. Okay. Then it goes into your pulmonary artery. When you're in pulmonary artery, you get pressure 12 to 25. Your systolic is 25. Your diastolic is 12. Okay. Then you wedge it. The moment get wedged in the pulmonary capillary circulation, it goes into 8 to 12. So it's around there. 8 to 12, 12 to 8. So this is, by looking at this waveform, we know where are we. Okay, that's why we get your pulmonary artery occlusion pressure or wedge pressure. So again, this is it. We cannot, the idea is you can only inflate the balloon 1.5 mil of air, and do not inflate the balloon more than 15 seconds, because you inflate the balloon for too long, to the pulmonary circulation, it can get pulmonary infarct. Okay. So right atrial pressure catheter, right ventricular pressure catheter, pulmonary artery pressure catheter, then pulmonary capillary wedge pressure catheter. You can see the changes in your waveform. 0, the transducer to the patient plebostatic axis, same like you do outline, measure the pulmonary capillary wedge pressure at end expiration. PCWP should not be higher than PA diastolic. PCWP is an indirect measurement of your left ventricle end diastolic pressure. This is what I mentioned here. Okay, we want to get a left ventricular end diastolic pressure. By getting all this pressure, then only we can calculate our cardiac output. Okay, when we measure, can come out in MCQ. If patient is being ventilated, you measure at end expiration. You look at your ventilator setting, You inflate and press the measurement. You inflate and wedge the pressure and press for the measurement when the patient is end expiration in a spontaneous end inspiration. It's very difficult for us to time this. This remember for MCQ. And what does during using Swan Ganz, what can be monitored? Continuously, you can measure pulmonary artery pressure. You see, your catheter is in your pulmonary artery. Okay, but without inflating the balloon, without inflating the balloon, you can measure continuously pulmonary artery pressure. Intermittently, when you inflate the balloon and occlude, you measure PAOP or PCWP. It's the same thing. Continuously, you measure pulmonary artery pressure, but intermittently, when you inflate the balloon, you measure pulmonary artery occlusion pressure. Because for you to measure the cardiac output, you need the pulmonary artery occlusion pressure. So Swan Ganz doesn't measure cardiac output continuously. It's an intermittent measuring. This is what different from Vigilio flat track, where they can give a continuous monitoring at a less invasive method. That's why we are moving out, go away from it. This one, you have to do it and you have to be worried about pulmonary infarction. You cannot inflate more than 15 seconds, all this nonsense. Continuously, we can measure SvO2. SvO2 is central venous, this is a mixed venous oxygen, okay? It is a pulmonary artery. Your pulmonary artery contains the full deoxygenated blood because all your venous return from systemic circulation goes via IVC and SVC to our right atrium. Not get oxygenated yet, is deoxygenated blood. Goes into right ventricle, still not oxygenated, and goes into your pulmonary artery. Your pulmonary artery, after that only it goes to the lungs, get oxygenated. So your pulmonary artery contains the full deoxygenated blood. Why is it called mixed venous? It's a mixed venous from upper body and lower body. Your upper body venous drainage is from your SVC. Your lower body is from your IVC. It's different compared to when you measure from the SVC. When you measure from your normal IJC, if you take a when you take a BBG or a blood gas, it's called a SCVO2. It's not called SVO2. It's called SCVO2, which means central venous oxygen, because it's only measuring from the upper venous, upper body of the venous drainage. You are not actually taking into consideration the IVC venous drainage yet. So that's why it's not so accurate. The mixed venous is the best at the pulmonary artery. It's the total deoxygenated blood. And you can continuously measure the temperature. This thermistor that you have, this thermistor that you have, you can continuously manage the core temperature of the patient, which is the most accurate one. The core temperature of the patient continuously measured. So this can come out in MCQ as well. Then what are the causes of your discrepancy? You can read on your own. This is what I mentioned about your zones just now. Okay, so when you have zones, there'll be a problem with all these things. So all this can happen. So what are the indication and contraindication? You can read on your own also. I'm not going to go into this much. Okay, that is about your PA catheter. You can read about PA catheter also in your Carey Brandeis. It's given very well in Carey Brandeis also. At the end page, at the chapter 12, at the back there, 200 plus, 200 pages, 200 plus. So please go and read Carey Brandeis on these two topics. Any question that you all don't understand about the equation or anything can ask me anytime. Any questions so far?